try to, for sure I will stay in time, give you what is going on in IRE. That's always a nice slide, and I don't think there are many others illustrating it nicely. I have no disclosures related to this presentation, not so ever with Angiodynamics. That image came from one of our earlier consultations, showing what at that time was frequently used by colleagues. This time we had another one, but you can see IRE is not the most highest rated, but it's coming up. It's the new kid on the block. Obviously, HIFU and cryosurgery are always number 1 and 2. So if we talk about projects, and I was involved with HIFU in the past as well, it took almost 30 years to position that technology. And the question is, how do we get it in guidelines? And for IRE, we have been moving into this stepwise approach, phase 1, 2, 3, and 4, which means you do basic research to prove that it works, whatever you are aiming at. Secondly, in guidelines, you need randomized controlled trials. There is never an ideal trial, and as was presented yesterday, to do a randomized study against a radical surgery or radiation therapy is almost mission impossible. Patients come once you have a program and want to be in that program. So if you have a focal therapy program, it's almost impossible to randomize. And you have smart ways to do that nowadays. The team from London has been working on that, but still it is very challenging. And then you want to have a registry. How does it work in the real world? And all these data, all together, they are important. It's not just that this randomized study generally says, wow, this is it, but you need all of these. That was phase 1 that we did. 16 patients did IRE, and they were all scheduled for radical prostatectomy. And what we learned from that is that wherever we put the needles, what was in that block of treatment, there were no skipped lesions. That's very important. And what we also learned is that actually the area that was treated was resulting in a larger zone. And as you can see, that's 2.7 times larger than the electrode configuration. So you need to keep this in mind. It's not just that you put needle and say, well, that's the area treated, but it may be larger. What also important is that you say, well, how can I properly follow up? How reliable is it, the match with one the other? So all the patients had an MRI and they had a contrast ultrasound before. And there was a very nice match to that. So with this technology, you can nicely predict the area that you treat. You know there are no skip lesions, and you know that you can see what you have been doing. The next step in the project we did is a phase 2 study, a randomized study. So these are the inclusion criteria. We're aiming at the nice patients, the ideal patients. Now, keeping in mind that this study was designed not to show oncological outcomes superior to anything else. This study was designed to show possible differences in a focal treatment versus an extended treatment. And then with respect to quality of life, continence, erectile functions. Of course, oncological outcome is in there, but not as primary objective. Otherwise, this study would be taken the next 5 to 10 years before you are able to report. You want to know on the short term how good we are doing. That is the follow-up schedule, and if you look at that schedule, it's very dense. What we learned from this, that during the study, we had to adapt a little bit the inclusion criteria because we moved away from transperineal biopsies, because some of the sites says, I cannot do this anymore, all this mapping. We moved also and included their MRI guided, you could see the lesion, and systematic biopsies. So what we learned from this, you can design a study, but by the time it's mature, the question is it still all valid? So you need to be a little bit flexible there. That study is now complete, actually by beginning of February, and we are now going to analyze that. So this year, these data will become available once there is a follow-up of at least 3 months. And then we had a phase 3. We discussed often, how are you going to treat, which are the patients you're going to include in the real world? And all these different scenarios are available. So we have included now close to 450 cases worldwide, and also we're going for a snapshot analysis. And the beauty of that project is that we will be able to continue for the oncoming years. You can expand that, and include that. So these are actually the studies that I'm aware of that I'm involved in with. That's another one coming from the London group. And the interesting thing is we said, well, this is focusing on MRI, guidance, treatment, but how good will MRI be able to predict that you have been treating the whole area? As we learned yesterday, sometimes the area is a little bit bigger. So this is the ideal approach for a project, and I think we have been doing well for IRE, and we have learned from what others have been doing. And with that, I would like to conclude my presentation. Thank you.